Welcome to week 6, problems of oxygenation and ventilation. This is part 1. The agenda for week 6 will consist of nursing care for the client with COPD and pneumonia, pneumothorax pleural effusion, and chest tubes and pleural drainage. Please ensure you review the respiratory system to ensure that you understand the different terminology that I'll be using, and it is in your textbook in chapter 28. So we are going to start with chronic obstructive pulmonary disease, better known as COPD. This definition is from the Canadian Thoracic Society. So chronic obstructive pulmonary disease is a respiratory disorder largely caused by smoking, and is characterized by progressive, partially reversible airway obstruction and lung hyperinflation. It does have some systemic manifestations, and it leads to increasing frequency and severity of exacerbations. COPD, there's 2 types, chronic bronchitis and emphysema, plus or minus asthma. Asthma is considered separately, and there are changing opinions as to whether or not it is a category of COPD, but for this lecture we're going to speak just to chronic bronchitis and emphysema, and typically these 2 coexist. So smoking is the most important predisposing factor of COPD. It has many effects on the respiratory system, including increased production of mucus, hyperplasia of goblet cells, and so hyperplasia means the enlargement of an organ or a tissue caused by an increase in the reproductive rate of cells, and it is seen in the development of cancer. Smoking also has effects on the respiratory tract with respect to lost or decreased ciliary activity. Also, in cigarette matter or particles is carbon monoxide, and it decreases the oxygen carrying capacity. Other risk factors include occupational and environment. So COPD can develop with intense or prolonged exposure to dust, vapors, irritants, or fumes, and high levels of air pollution. Other risk factors include infection. Typically, individuals with pneumonia have recurring infections that impair the normal defense mechanisms. These infection rates also intensify the pathological destruction of lung tissue, and it's seen very often as a co-infection with HIV, and TB is a risk factor for COPD. Hereditary. The alpha antitrypsin deficiency is seen in emphysema, so it's a genetic risk factor for emphysema. It is found in chromosome number 14, so it's an inherited genetic disorder of chromosome 14. Lower levels of AAT result in insufficient inactivation and subsequent destruction of lung tissue. And it's seen in young clients without a smoking history. That's how it's first diagnosed, is that you have these young individuals with emphysema that do not smoke. And lastly, aging. As people age, there's gradual loss of elastic recoil of the lungs. The lungs become more rounded, they're smaller, and the number of functional alveoli decreases as peripheral airways lose supporting tissues. So very common to see this as individuals age. But these changes are similar to those seen in the client with emphysema. And so clinically significant emphysema, however, usually is not caused by aging alone. So let's look at the pathophysiology. The primary process is inflammation. So it starts with an inhalation of noxious particles. An inflammatory process takes place, which causes damage to the lung tissues, the airways become inflamed, and the parenchyma is destroyed. Parenchyma is that tissue that's involved in gas exchange, so the viable or functional tissue matter in the lungs. Supporting structures of the lung are destroyed, and so what happens is air goes in easily but remains in the lungs. The bronchioles tend to collapse, and it causes this barrel chest look of individuals. So the barrel chest is on the right side. Common characteristics are mucus hypersecretion, dysfunction of cilia, hyperinflation of lungs, and gas exchange abnormalities. And the gas exchange abnormalities result in hypoxemia and hypercarbia, which is increased CO2 as the disease worsens. So these are the lung changes in COPD. On the left, you can see the normal lungs, the bronchioles and the alveoli, and on the right are the lungs in a patient with COPD. So the bronchioles lose their shape and become clogged with mucus, and the walls of the alveoli are destroyed, forming fewer, larger alveoli. So again, a decrease in gas exchange happens. So if we look at this cartoon, it's actually a great cartoon showing the main clinical manifestations of COPD. So as you can see at the top, you have the chronic airflow limitation with both emphysema and chronic bronchitis. And so some of the manifestations you see are individuals are easily fatigued, frequent respiratory infections, use of accessory muscles to breathe, orthopnea, so shortness of breath while lying flat, cor pulmonale, which is right-sided heart failure, which I'll speak to. They often appear thin in appearance. There may be wheezing. Individuals often use this pursed lip breathing to help them with the expiration. A chronic cough, barrel chest, shortness of breath, prolonged expiratory time. That's when they're using that pursed lip breathing, and digital clubbing. And some of these I'm going to discuss as we move forward. But the cardinal signs of COPD are dyspnea, chronic cough, and sputum production. So looking a little bit closer specifically at chronic bronchitis and emphysema. So again, chronic bronchitis is more about inflammation. So this chronic inflammation of the lower respiratory tract, and it also goes along with this excessive mucus secretion, cough, and shortness of breath. Those are typically what you see in chronic bronchitis. And so the bronchial walls become thickened, the bronchial lumen is narrowed, and a mucus plug may block the airway. There's large and small airway obstruction, which is associated with chronic irritation from smoking and recurrent infections. In emphysema, you have destruction of the alveoli, enlargement of distal airways, and breakdown of the alveolar walls, and you have a loss of this elastic recoil. And so in emphysema, the alveoli walls are destroyed, and the surface area that's in contact with the capillaries decrease. And so what happens is you have an increase in lung area where no gas exchange can occur, and you have this dead space, and that's what causes the hypoxemia. The ability to get rid of CO2 is decreased, and hypoxia becomes the driving force for the client to breathe. Eventually, you have increased CO2 and respiratory acidosis. So let's look at this diagram of a chronic bronchitis. And chronic bronchitis has a name of a blue bloater. So let's go through some of these. So obviously we have an airflow problem. The color of the skin appears to be dusky to cyanotic. And so that is because what's happening there is patients hypoventilate. They have a diminished respiratory drive and they develop hypoxia. Chronic hypoxia causes the kidneys to produce erythropoietin. So erythropoietin is a hormone produced by the kidneys, which tells the kidneys to produce red blood cells. And so if someone's in a chronic hypoxic state, this hormone's constantly telling the kidneys to produce red blood cells. And this leads to polycythemia. And polycythemia refers to an increase in the number of red blood cells in the body. And so what happens is you have a high hemoglobin levels because of this increased production, but the amount of hemoglobin that comes in contact with oxygen is low because of the hypoxia, and so therefore you have this cyanosis that develops. And so that's why you get this blue bloating. You can have hypercapnia, which is an increase in your PCO2 because you're holding on to, so it's very hard to expire. So your inspiration, expiration is very hard, so you have a trapping of CO2, which can cause the respiratory acidosis. I've talked about the increased hemoglobin. You have a high respiratory rate, dyspnea, it's more common in smokers, and you have digital clubbing, which I'll talk about next. The other things that you see in chronic bronchitis are cardiac enlargement, which is because of this right-sided heart failure. And I also will discuss this next. And then typically you see the use of accessory muscles. So pulmonary hypertension results from COPD and chronic bronchitis, and this can lead to cor pulmonale. Cor pulmonale is basically right heart failure. It's on a hypertrophy, so a right ventricular hypertrophy, so an enlargement of the right ventricle because of the mass. The right ventricle is trying so hard to pump, but it can't, and so you get this enlargement of the right ventricle with right heart failure. So the mechanism behind this is that pulmonary hypertension is a condition that is increased blood pressure within the arteries of the lungs, and it's caused by COPD. So when pulmonary hypertension develops, the pressure on the right side of the heart must increase to push blood into the lungs. And so what happens is it causes the right ventricular pressures to increase, and that leads to kind of a backflow into the systemic circulation. So you have an increase in venous pressure, which leads to distended neck veins, and everything kind of gets backflowed up through the right ventricle, through the right atrium, and into the right side of the body. So you have your increased jugular veins, you have liver engorgement, you have peripheral edema. It can lead to ascites, weight gain, and it also leads to cor pulmonale. Sorry, that's supposed to be just one E here. Also leads to cor pulmonale, which is right hypertrophy with right heart failure. So if you look at this, this is the right ventricle here, and it's trying to pump out into the pulmonary circulation so it can go through the typical ventilation, this oxygen and CO2, which comes back into the left atrium and then left ventricle. But what's happening is this right ventricle is having a really hard time pumping out, and so you have an enlargement and a right ventricular failure, and you'll also have some backflow coming back into the right atrium, which is going to go back into the systemic circulation. This was the clubbing that I wanted to talk about, and so you see this abnormal clubbing of the fingernails. So it's abnormal rounding of the nail beds due to low oxygen levels. I want to talk a little bit about emphysema. They are typically called the pink puffer. So people with emphysema are called pink puffers because they have difficulty catching their breath and their faces redden while gasping for air. It's also related to an increase in the CO2 retention. So with emphysema, it's an alveolar diffusion problem. These individuals usually use the technique of pursed lip breathing, and this technique helps to keep the airways open longer so they can remove the air that is trapped in their lungs by slowing down their breathing and relieving some of their shortness of breath. Emphysema is all about the air trapping, and I'll speak to that on the next slide. You have an increased respiratory rate, orthopneic, a barrel chest, exertional dyspnea, prolonged expiratory time. That's the difficulty, is trying to get rid of the air because of the trapping that takes place. They tend to speak in short, jerky sentences. They're anxious. They use accessory muscles to breathe, and they have a thin appearance. So emphysema is all about the air trapping. So after the alveolar walls are damaged or destroyed, they can't support and keep the airway open. The alveolar walls lose their capability of elastic recoil, and the collapse then occurs on expiration. So in the normal lung, you have the recoil of the alveoli to push the air out of the alveoli. But with emphysema, you have impaired expiration. So you have the damaged walls of these small airways become obstructed, but it's more so the loss of elasticity and elastic recoil. There's the inability for the alveoli to snap back. And so you have this inability to get the air out. So you have overinflated lungs. I'm going to show this quick video on COPD and the differences between blue bloaters and pink puffers.
COPD, or chronic obstructive pulmonary disease, is a common respiratory condition involving the airways and is characterized by airflow limitation. Exacerbations and comorbidities contributes to the overall severity in individual patients. Let's look at the signs and symptoms of COPD. So patients with COPD present usually with three cardinal symptoms, and these are dyspnea, chronic cough, and sputum production. Less common symptoms include wheezing and chest tightness. Risk factors for COPD include smoking in 95% of cases, so it's a big risk factor. There's also air pollution, low birth weight, recurrent lung infections, and cannabis smoking. Low socioeconomic status and alpha-1 antitrypsin deficiency are also risk factors for COPD. COPD again stands for chronic obstructive pulmonary disease and encompasses a variety of diseases. The big three COPD chronic obstructive pulmonary diseases are chronic asthma, the blue bloaters, which is the chronic bronchitis, and the pink puffers, which is emphysema. In this video, we will mainly focus on the blue bloaters and pink puffers. But before looking at these two, let us quickly revise asthma. And I have a video that actually looks into more detail on asthma if you're interested. So asthma, it's a chronic inflammatory disorder of the airway in which many cells and cellular elements play a role. Recurrent episodes of wheezing, breathlessness, chest tightness, and coughing are only some signs and symptoms of asthma. So now we will talk about the blue bloaters and the pink puffers. And here I am drawing a diagrammatical, representation, a stereotypical representation of patients that present with chronic bronchitis as well as emphysema side by side, blue bloaters and pink puffers. We will use this to compare the difference between the two chronic obstructive pulmonary diseases, beginning by looking first at the blue bloaters. So the blue bloaters, these are patients that look very cyanosed blue. Bloaters potentially due to the dyspnea, severe dyspnea, and lack of exercise. So in chronic bronchitis, you have inflammatory change leading to mucociliary dysfunction and increased goblet cell secretion and numbers, which leads to excessive mucus production. So if we look at a normal alveoli, it has oxygen coming in and carbon dioxide going out, normal ventilation and perfusion. These are alveoli, and it has elastic fibers surrounding the alveoli, which is important for basically the air recoiling during expiration. So when you exhale, it recoils back, pushing the air out, and we breathe this carbon dioxide out. Now, if we look at an alveoli and the bronchioles of a chronic bronchitis patient, we can see big differences. In the bronchioles and bronchi, we see bronchoconstriction and mucus hypersecretion. The mucus hypersecretion leads to the productive cough in chronic bronchitis. The airways obstruction from bronchoconstriction and mucus leads to wheezing. And we hear wheezing during expiration, typically. When we have airway obstruction, this also can mean that we have alveolar hypoxia because oxygen is not getting through to the alveoli efficiently. This leads to a VQ mismatch. The VQ mismatch leads to hypoxemia and hypercapnia. Hypercapnia means respiratory acidosis. A decrease in oxygen in the blood means the body will try to make more red blood cells to compensate. This is known as polycythemia, where we get an increase in hemoglobin. The respiratory acidosis and polycythemia with the decrease in oxygen contributes and basically means cyanosis, the blue color. And this is why these patients with chronic bronchitis are known as the blue bloaters. So just recapping, chronic obstruction means that during respiration, less oxygen comes in and less carbon dioxide goes out, which leads to decrease in oxygen in the blood and increase in carbon dioxide in the blood. Because in chronic bronchitis, oxygen is not properly getting into the alveoli, we get alveolar hypoxia. When this happens, the pulmonary vessels will constrict so that it can shunt the blood flow to healthier alveoli. But when you get pulmonary vasoconstriction, you can get an increase in pulmonary vascular pressure, so pulmonary hypertension. When you get pulmonary hypertension, this can cause backflow of blood to the right side of the heart, and this can cause right-sided heart failure, which causes your cor pulmonale, leading to the increase in jugular venous pressure. I hope that makes sense. Now, going back to the alveolar hypoxia again, remember that the pulmonary vasoconstriction of some vessels leads to the pulmonary hypertension. So pulmonary hypertension leads to less blood going to the left side of the heart, which means that there can be a decrease in left ventricular cardiac output, and this means a decrease in circulatory volume. Now, a decrease in circulatory volume results in the activation of the renin-angiotensin-aldosterone system, which causes more fluid retention, despite still having fluid piling up in the lungs. And of course, this is in more severe cases. So I hope that all made sense. So that was for the blue bloaters, chronic bronchitis, and they are cyanosed. They present with wheeze and also productive cough. Not productive, but very prominent cough. Now let us look at emphysema. Emphysema are known as the pink puffers. Very skinny, muscle wasting, but prominent thoracic cage, barrel-chested. And we will see why. So emphysema is an inflammatory response which leads to elastic fiber breakdown and destruction of the alveolar walls, which means loss of alveolar integrity. And so we lose alveolar recoil as well. This leads to a phenomenon known as air trapping, which is typical of emphysema patients. So if that all did not make sense, we'll look at it in a diagram. So let's draw the same diagram as before with the bronchiole and the alveolus here, and its pulmonary supply. Now within the alveolus, there are macrophages normally residing in there, helping to keep the place clean and sterile. And normally, again, oxygen comes in and carbon dioxide goes out. Now with emphysema, due to smoking or inhalation of pollution or other toxic substances, the macrophages can become stimulated and begin secreting proteases and cytokines, which lead to a number of things. The cytokines released attract neutrophils from circulation to move into the area. The neutrophils, as a consequence, begin secreting a special protease called elastase, which specifically targets the elastic tissues. So elastase secreted by the neutrophil leads to loss of elastic fibers around the alveolus, which would mean loss of elastic recoil, which means decrease in ventilation. The proteases secreted by macrophages and the neutrophils also lead to the destruction of the alveolar wall and capillary beds. The destruction of the capillary beds leads to a decrease in perfusion. And so, as you might realize, we have a big problem with the ventilation and perfusion ratio. The loss of elasticity and destruction of alveolar wall leads to air trapping. Air trapping is basically when you still have a lot of gas trapped in the alveolus after you expire, after you exhale. So you have oxygen and carbon dioxide trapped there still after you exhale. This means you have an increase in end expiratory volume. So because you have an increase in end expiratory volume, this leads to one of the clinical signs of emphysema, which is barrel chest. Because you are not emptying your lungs, you still have gas trapped. and you're using accessory muscles and a lot of effort in breathing, all these together lead to the barrel chest. Okay, so the decrease in perfusion and the decrease in ventilation, which we talked about earlier, leads to a matched VQ deficit. As a result of this deficit, in the blood, you see similar things to chronic bronchitis, a decrease in oxygen and an increase in carbon dioxide in the blood. So recapping what we just drew on the diagram, the proteases released by macrophages and neutrophils damages the elastic fibers, leading to decrease in elastic recoil, which means a decrease in ventilation. The proteases also destroys capillary beds, which means a decrease in perfusion. Decrease in ventilation and perfusion means we have a matched VQ deficit. As a result of this VQ matched deficit, we get hypoxemia and hypercapnemia. I think that's how you say it. Hypoxemia and hypercapnia in the blood becomes more severe in late stage. The loss of elastic recoil is due to the loss of alveolar integrity and the destruction of the alveolar walls. And so the person needs to work a lot harder to breathe in. As a result, we get dyspnea and also cachexia. Now, alpha-1 antitrypsin deficiency is a hereditary condition, which means that if you are deficient in antitrypsin, you cannot defend against proteases, and so you have a net too much protease and less antiprotease, which means you get a net damage to your lungs, essentially. So I hope all that makes sense about emphysema. So emphysema are your pink puffers, chronic bronchitis are your blue bloaters.
So let's move on to COPD complications. So the main ones are cor pulmonale, which we've already spoke to. Exacerbations of COPD are usually related to, if someone with COPD will typically go along fairly well, let's say for a COPD, they'll be short of breath on exertion. They may not be able to lie flat. They may have the productive cough, but they can have an exacerbation, meaning a worsening time with their COPD, and it's usually related to infection or non-infectious causes such as air pollution, allergens, irritants, cold air. So typically you see the non-infectious causes happening in the summer where the pollen is a lot worse or it's very humid. So things like that. Acute respiratory failure is caused by these exacerbations in cor pulmonale. Maybe someone discontinuing their bronchodilator or their corticosteroid medication, maybe poor judgment in the use of sedatives or opioids. Someone who's coming in for surgery involving the chest or abdomen might have acute respiratory failure. And so anyone that's coming in for surgery needs careful preoperative screening, which includes making sure that pulmonary function tests are done, ABGs are done, and it's important in clients with a history of heavy smoking and COPD to prevent any postoperative complications. Peptic ulcer disease, there's found to be an increase in peptic bleeding, ulcer bleeding related to COPD, and then depression and anxiety. Approximately 40% of COPD clients experience depression. And if a client becomes anxious because of shortness of breath, it's important for nurses to teach that pursed lip breathing. What about diagnostic studies? Well, diagnostic studies are through chest x-rays. Spirometry or pulmonary function test is a gold standard, and typically what you see on the spirometer test are a reduced FEV1 and FVC ratio and an increase in residual volume with that air trapping. And so over here you can see what FEV1 is, the amount of air you can blow out of your lungs in the first second of taking the test. And so it would be reduced because as we've seen with emphysema, it's very hard to blow that air out. And forced vital capacity is the largest amount of air that you can blow out after you take your biggest breath in. So it's all about that expiration. Diagnostic studies, so your ABGs, typically they are hypoxic or hypoxemia, so a low PaO2. We've talked about the increase in CO2, a decrease in pH, remember the opposite respiratory acidosis, and sometimes an increase in bicarbonate levels found in the later stages of COPD. And I would probably think that's a compensatory mechanism. Other diagnostic studies are the 6-second walk test to determine the oxygen saturation in the blood with exercise. ECG can show signs of right ventricular failure, remember cor pulmonale. And then collaborative care. So your endpoint is to prevent progression, reduce the frequency and severity of exacerbations, to help the clients alleviate their breathlessness, improve their exercise tolerance and daily activity, treat the exacerbations and complications, improve their quality of life, reduce their mortality risk, and encourage smoking cessation. Other areas are O2 therapy, are used to reduce the work of breathing, maintain the PaO2, and reduce the workload on the heart. But COPD affects the oxygen saturation levels in different ways. So this is very important when you're looking at oxygen and saturation, and you typically, with any patient that's COPD, you tend to keep their saturation levels, very rarely do you go above 88, 92%. And so in a normal individual, the drive to breathe is guided by chemoreceptors in the respiratory center that respond to changes in carbon dioxide and oxygen levels. Normally, when we have an accumulation of carbon dioxide, it's a stimulant to the respiratory center to get breathing. But over time in COPD, the respiratory center loses its sensitivity to elevated carbon dioxide levels because it's constantly increased. And so some COPD patients develop a tolerance for high carbon dioxide levels, and so they don't have that stimulus in the respiratory system. And so in theory, for these individuals, the drive to breathe is hypoxemia, not the CO2 levels. And so administering oxygen to patients with COPD has been thought to weaken their drive to breathe. And so keeping the SAT above 90 to 92 is that your bottom number is about 90% because they need to be a little bit hypoxic or have hypoxemia in order to drive themselves to breathe. And so what is important is that it's careful, ongoing physical and cognitive assessment when oxygen is provided to these patients to kind of document where their CO2 levels are they developing O2 toxicity? And so when you'll learn this about the importance of keeping the saturation at a lower level. So let's move on to pneumonia. So pneumonia is acute inflammation or infection of the lung parenchyma. So remember, parenchyma is the functional tissue of an organ caused by microbial organisms. So in this case, it can be anything from bacteria, virus, fungal, parasites, and chemicals. So I'm going to show you a quick video on pneumonia.
Pneumonia is an acute infectious process of the alveoli that can affect one or both lungs. Pneumonia is most often caused by bacteria, but may also result from viruses, fungi, and other microbes. Organisms typically enter the lungs during or following an upper respiratory infection. The alveoli fill with purulent material when the body's natural immune defenses are vulnerable, resulting in pneumonia. Symptoms of pneumonia may include cough, shortness of breath, chest discomfort, and lethargy. Symptoms of bacterial pneumonia are usually more severe, include a high fever, and have an abrupt onset. Treatment of pneumonia may include supportive care, rest, fluids, oxygen if needed. Bacterial pneumonia may also be treated with antibiotics. There is a risk that the infection may spread into the bloodstream, causing bacteremia. In severe cases, fluid may develop outside the lung, leading to respiratory failure. Children under the age of 5 years are at particular risk for developing pneumonia. The Haemophilus influenza type B, Hib, DTaP, and pneumococcal vaccines are important childhood vaccines that help prevent common types of pneumonia in children.
So this is just, again, a diagram of the normal alveoli and pneumonia. So again, pneumonia is an acute inflammatory process that produces excess fluid in the lungs. And the inflammatory process in the lung parenchyma results in edema and exudate that fills small airways and the alveoli. The alveolar sacs become so filled with fluid that the exchange of oxygen and carbon dioxide is reduced. The fluid in the sacs become consolidated and is increasingly hard to cough or expectorate. It's important to understand the mucociliary mechanism. So these are our defense mechanisms in our lungs. So mucociliary and cough clearance are part of the innate host system of the respiratory system, and it's important for keeping the airways cleansed of bacteria, virus, and toxic particles. So what are the causes? Now we know that it's caused by some type of microbe, but it's likely to result when our defense mechanisms become incompetent or are overwhelmed. And so this can result from a decreased level of consciousness, individuals with a decreased cough or reflexes, epiglottal reflexes, may allow aspiration. So think about your stroke patients, your spinal cord injury patients, and then the mucociliary mechanisms are impaired. So I spoke about that on the previous slide. So mucociliary mechanisms can be impaired from pollution, cigarette smoking, viral upper respiratory infections, tracheal intubation, and then just the normal changes with aging. So 3 ways organisms reach the lungs: through aspiration, through inhalation of microbes, and through the blood. So homogeneous spread from primary infection elsewhere in the body. So let's look at the types of pneumonia. Community-acquired pneumonia is the most common and usually occurs from influenza. It's a lower respiratory infection. Onset in the community or during the first 2 days of hospitalization is when it typically shows up. Highest incidence in midwinter. Smoking is an important risk factor. Hospital-acquired pneumonia is diagnosed greater to or equal to 48 hours after admission and not incubating at time of hospitalization. So you don't present with fever, cough. So this is something that's acquired, and it must be greater or equal to 48 hours after admission. It accounts for 25% of all ICU infections, and the risk factors are individuals who are immunosuppressed, just general debility, and endotracheal intubation and ventilation. Other types of pneumonia are aspiration pneumonia. So it's a sequelae occurring from abnormal entry of secretions into the lower airway. What conditions put individuals at risk? Those would be individuals with decreased level of consciousness, so your seizure, anyone who's had an anesthetic, a head injury, stroke, alcohol intake, difficulty swallowing, nasogastric intubation with or without tube feeds. These are all reasons that someone would aspirate. Opportunistic pneumonia is a pneumonia that goes along with another illness. So clients with altered immune response are highly susceptible to respiratory infections. So your HIV patients, your TB patients, other patients would be malnutrition, your immune compromised transplant patients, and your cancer patients with chemo and radiation. Clinical manifestations: sudden onset of fever, chills, cough productive of purulent sputum, pleuritic chest pain, dyspnea, tachypnea, increased respiratory rate. I never know how to say that. Note, in the elderly or debilitated client, confusion or stupor, possibly related to a hypoxia, may be the only finding. Physical examination: dullness to percussion over the area, over the lobe that is infected, increased fremitus, so go back to your health assessment notes, bronchial breath sounds, and crackles. Bronchial breath sounds is that hollow sounding, as if you were listening over the bronchial area. It's the same bronchial hollow sounding. It's because of the consolidation in the lung, and you can hear crackles. Tips for assessing respiratory infections: I is for respiratory or pulmonary infection. N is need to assess response to activity tolerance and track the vital signs. So typically your increased respiratory rate, your saturation, your heart rate. Fever, monitor your fever, but again, it's not a reliable assessment in the elderly. E is you have elevated white blood cell count. Exertion causes shortness of breath. Shortness of breath may occur with or without exertion. Productive cough, crackles, wheezing, increased respiratory rate and tachycardia, increased mucus production, and there could be a change in color, viscosity, quantity, and odor. O2 saturation is decreased, and note restlessness or an alteration in level of consciousness, especially with your elderly patients. Complications are pleurisy, which is an inflammation of the tissue layers or the pleural lining of the lungs and the inner chest wall. It causes a sharp pain and it worsens during breathing. Pleural effusion, we're going to learn about that in our next part 2. It's an accumulation of fluid in the pleural space. It happens with 40% of clients. Happens with 40% of clients and may require thoracentesis, so the removal of fluid. And atelectasis is the collapse of the alveoli, and it usually clears with coughing and deep breathing, and it allows those alveoli to reopen. Diagnostic tests are commonly chest x-ray, a sputum culture and sensitivity, pulse oximetry or ABGs, CBC and differential, and blood cultures to see if there's any septicemia. Treatment is based on the risk factors and the bacteria that's responsible for the infection. Remember that contaminated respiratory therapy equipment is another source of infection. Hospital-acquired infections, often you run up against multi-drug resistant organisms. Collaborative care includes oxygen for hypoxemia, analgesics for chest pain, antipyretics, antitussive antitussives are for cough, bronchodilators, a high-calorie diet and adequate fluid intake, mechanical ventilation if the patient goes into respiratory failure with PEEP. Remember the positive end expiratory pressure. Go back to your mechanical ventilation lecture. And preventative is the pneumococcal vaccine. That is it. And I will see you in part 2 when we speak about pneumothorax, pleural effusions, and chest tubes and thoracentesis.